All right, let's jump right in. Today, we're going to tackle a topic that's absolutely fundamental in orthopedics, complex forearm fractures. Now, these aren't your run-of-the-mill breaks. They're actually really intricate injuries that teach us a massive lesson about how we approach trauma in general.
So let's start with a question that really gets to the heart of it all. Why is it that if you see an X-ray with what looks like a simple, isolated fracture of just one forearm bone, say the ulna, you should immediately get suspicious? It seems like a paradox, but once you get the concept, it'll totally change how you look at extremity films forever.
And here's the answer. It's all about anatomy. You have to think of the radius and ulna not as two separate bones, but as a single functional ring. They're connected at the elbow, they're connected down at the wrist, and they're connected all along their length by that super tough interosseous membrane. Now think about it. You can't break a solid ring in just one place. It's physically impossible. If you apply force, it has to break or dislocate in a second spot.
Okay, so this ring principle leads us to two classic must-know injury patterns. You're definitely going to see these on your exams and in the clinic. First up is the Monteggia Fracture dislocation.
So what exactly is a Monteggia? It has two key parts. First, you get a fracture in the proximal third of the ulna. That's the upper part closer to the elbow. And second, because of that ring concept, the energy has to go somewhere. So what happens? The radial head gets forced out of the elbow joint. It dislocates. The ulnar break allows the radial head to just pop right out of place.
Now, let's look at the second classic pattern. And what's cool is that it's basically the mirror image of the Monteggia. This is the Galeazzi Fracture dislocation.
And this just perfectly shows that inverse relationship. In a Galeazzi, the fracture is in the distal third of the radius, so down closer to the wrist. And the associated injury? It's a disruption of the distal radio-ulnar joint, the DRU, right there at the wrist. So let's lock this in. Monteggia is a proximal ulna fracture with an elbow dislocation. Galeazzi is a distal radius fracture with a wrist dislocation.
Okay, so recognizing the patterns is step one. But what do we actually do about them? Let's talk about the treatment and the single biggest complication you have to be on the lookout for. For these kinds of unstable displaced fracture dislocations, the choice is, well, it's pretty much a no-brainer. Sure, if you have a perfectly non-displaced fracture, maybe you could treat it in a cast. But the vast majority of Monteggia and Galeazzi injuries are inherently unstable. They absolutely require surgery to get things lined up and stable again.
The standard of care here is what we call an ORIF. That stands for open reduction and internal fixation. Let's break that down. Open reduction just means the surgeon makes an incision to see the bone directly and put the pieces back together perfectly. Then comes the internal fixation part, where they use hardware to hold it all in place. Most of the time that means using strong locking plates and screws, or sometimes they'll place a rod called an intramedullary nail down the center of the bone.
But here's a really critical point. Even if the surgery is mechanically perfect, the plate is on just right, the alignment looks beautiful on an X-ray, that doesn't guarantee healing. The problem actually shifts from being a mechanical one, like carpentry, to a biological one, more like gardening. And that big biological challenge is something called non-union. This is a really common complication with these injuries, partly because the blood supply to some parts of the forearm bones isn't that great. Non-union is when the bone just fails to heal. It doesn't form that solid bridge of new bone across the fracture. Healing can be super slow, and if a non-union happens, it almost always means the patient is heading back to the OR for another surgery, maybe even with bone grafting.
So, after all this, the patterns, the treatment, the complications, what's the one big takeaway? What's the single most important clinical rule that these specific fractures drill into our heads?
This is it. This is the golden rule. Monteggia and Galeazzi are the ultimate examples of why this matters. If you only x-ray the shaft of the ulna but you forget to get a good view of the elbow, you will miss that dislocated radial head. If you only look at the radius fracture and you don't check the wrist, you will miss the DRUJ injury. And this rule applies to every single long bone in the body. It's a simple, fundamental principle that will save you and your patients from some absolutely devastating missed injuries.